That's true. Yeah, that's true. That's very true. What do y'all have to say?
Whatever it is in there.
It's kind of painful. It causes a lot of fibrosis. It definitely makes the case. I know. You doesn't like saying no, I mean, it's more painful, but we'll get through it.
Yeah.
Y'all have fun.
I will.
Come by there and check them out. Don't let it worry you. So, tell me again, patient, what's the job that you're doing? tell you admission requirements, you need patient contract hours. Perfect. So how long do you do it?
Whatever you get ready to, you can just take off.
Good afternoon, everyone. Thank you for coming to the noon conference today. I appreciate the invitation from Ascension to have me present here locally, as well as streaming across the country for those of you who are logging on. The topic today is telehealth and thyroid disorders for the primary care provider. My name's Dr. Richard Rosenthal, and I'm an endocrinologist at UAB, a professor of medicine and associate chief medical officer for ambulatory services. I run sort of a private practice type of a clinic, see lots of patients with diabetes, and over the last 2 decades have had a special interest in taking care of patients with thyroid disorders. During the pandemic, as everyone adjusted and pivoted to a different way of taking care of patients, telehealth became very big at UAB, and we had a lot of strong leaders at our institution that made it a little easier to take care of these patients. So what I did in this presentation was basically came up with some case vignettes to talk about how you would go through the management strategy of a thyroid patient, diabetic for that reason as well, and some of the things you kind of work through to make sure you're properly taking care of them and not ordering a unnecessary test for these patients. So the first case is a 50-year-old a white female who presents for a TER visit. That's our telehealth visit, how it comes up in our computer system, for a recently discovered thyroid nodule. She has no previous history of thyroid disease, and on examination, I was able to visualize a 4-centimeter mobile thyroid nodule in the right lobe that did not move with glutition, which is swallowing. So when you see a patient like this, which of the following blood tests would be the most helpful in establishing the diagnosis? And these are board type questions for those of you who may be trying to recertify or take them for the first time, or things like that, or teach some of your residents or fellows. Choice A would be serum thyroxine, which is a T4 level. B is a serum T3 level, or triiodothyronine. C is a serum thyrotropin level, which is a TSH value. D are anti-thyroid antibodies. E would be none of the above. And the correct answer on evaluating a nodule, the first thing you need to do to kind of go down the algorithm is get a TSH. Because if the TSH is normal, you want to proceed on with biopsying that nodule or setting the patient up for a fine needle aspiration biopsy. When we do biopsies of thyroid nodules, most of these end up being benign, so it's an important thing to let your patients know that about 90 to 95% of the nodules will be benign. 5 or 10% of them will be cancer, and in those we end up doing a lobectomy or a total thyroidectomy at the discretion of a surgeon. Sometimes when we do biopsies, we don't get enough of the tissue and we have to repeat them. Those are considered insufficient samples. And then indeterminate lesions are ones that you probably may recall from your training where you couldn't tell one way or the other. And those come back as what we call a follicular lesion of undetermined significance. 20 years ago, those went to the operating room, and 80% of them were benign, 20% were malignant. These days, we do molecular testing on these nodules. We do Afirma at UAB, and it is a send-out lab that kind of help you determine whether the nodule should stay in or come out. Even when we tell a patient that their nodule is benign, we're wrong 5% of the time. That's a negative predictive value, and that's why we want to continue to follow these thyroid nodules very closely. We also use our radiologists who have developed a TIRAD scoring system that is very helpful in determining which nodules have certain concerning features. So in this particular patient, she did not have a normal TSH, so we didn't do a biopsy on her. Her TSH was suppressed. And when you have a suppressed TSH, the next thing to do is to do a thyroid scan and an uptake, because if the patient has a hyperfunctioning nodule, those do not need to be biopsied. 99.9% of those are benign. The definition of subclinical hyperthyroidism is a patient who has a low TSH in the presence of a normal T4 and a T3. There's several causes of subclinical hyperthyroidism, often the cause of several consultations that we get because the TSH is slightly below the normal range. And you see the potential reasons. A very common one is the patient's on a touch too much Synthroid or levothyroxine. In those cases, we tend to back off on the thyroid medicine just a little bit. I tend to tell them to skip 1 day a week or skip 1 day every other week, and that'll tend to normalize the thyroid levels. A slightly suppressed TSH does not need to lead to multiple imaging tests right away. These patients may have a multinodular goiter, they may have an autonomously functioning nodule, they may have thyroiditis, they may have Graves' disease, so there's a whole spectrum of things that these patients can have. On the flip side, what is subclinical hypothyroidism? Basically the reverse, a TSH that is slightly elevated with a normal free T4 and a normal TSH. Usually these are caused by autoimmune thyroiditis or Hashimoto's thyroiditis. We treat these patients with, sometimes with thyroid hormone therapy, sometimes we just watch their thyroid levels. This is a scan of that hyperfunctioning nodule that I mentioned before, showing the increased uptake here in the right lower lobe of the thyroid. These are treated either with surgery or our nuclear radiologists can give them radioactive iodine, usually concentrates at the nodules. Some patients may develop post-ablative hypothyroidism and need to be on thyroid hormone replacement. So you'd want to get this patient back in 6 weeks or so and recheck their thyroid levels. TSH levels can vary in different populations. White populations tend to have a slightly higher TSH level on analysis of several studies. As patients age, we commonly see a slightly elevated TSH. If an 80 or an 85-year-old lady comes in and she's on 100 of levothyroxine and her TSH is 6, I don't think she needs 125 of levothyroxine. I would just watch that because the normal mechanism of aging is for that TSH to slightly drift. TSH values also tend to be slightly higher in our overweight patients because leptin, which is common in these patients, stimulates thyroid releasing hormone, which in turn will stimulate, lead to increases in thyroid stimulating hormone. So who is at risk for hypothyroidism? This is just sort of a laundry list of different types of patients, those with family history of autoimmune disorders, patients who have type 1 diabetes, who have adrenal insufficiency. We see it commonly in our postpartum population. Those patients that may have Turner's or Down syndrome are a little bit more common to have hypothyroidism. Patients who have had previous neck radiation therapy for ENT type cancer may have slight elevations in TSH. The other common thing we see in clinic, which tends to be a little bit of frustration on the consultations, are patients who sort of think they have hypothyroidism and they have normal thyroid levels. So if you look at the symptoms and signs on the right side of this slide, weight gain, cold intolerance, slow thinking, goiter, constipation, a whole list of things that could be related to several disorders. It could be related to depression. It could be related to a rheumatological condition. So we have to be very careful in deeming someone hypothyroid just based on their signs and symptoms. In fact, the most sensitive indicator of any kind of thyroid dysfunction is the TSH value. And if that TSH is normal, it's unlikely that these signs and symptoms are going to be related to the thyroid. I did see a patient yesterday who was very interesting. He came in, and once I looked at all the records, his reason for referral was a TSH of 175, upper normal's 5. And this guy carried a little extra weight. He was fairly energetic, but he said that he could not really move his muscles. When he got down in a squatting position and tried to raise, he was incredibly fatigued. He had no muscle strength. His voice was kind of garbled. He couldn't really speak very clearly. He reported that his primary doctor 2 weeks ago had noted that his thyroid levels were abnormal and properly started him on a low dose of thyroid hormone, 50 micrograms, because you don't want to induce any kind of ischemia cardiac-wise in a patient that's been sort of living a little hypothyroid. This guy said that he could not believe how much better his symptoms were just with that 50 of Synthroid. So I've always spent a lot of time thinking about muscle strength and muscle weakness, as well as the way they speak as being some of the things that you may pick up on hypothyroidism. He also had a very elevated creatinine kinase into the 4,000s, and he was felt to maybe have rhabdomyolysis, but that CPK elevation was from his hypothyroidism. So again, the most common cause of thyroid dysfunction in someone that's hypothyroid is Hashimoto's thyroiditis. Women account for about 95% of the patients, about 2 to 15% of the female population is affected. The other thing that you may want to consider in these patients who come in with a history of hypothyroidism is getting thyroid antibodies. Because if a patient has a TSH sort of in the upper range of normal and they do have positive thyroid antibodies, that may be a reason to put them on low-dose thyroid hormone, because as time goes on, about 1 to 2% of those patients who have positive thyroid antibodies will go on to develop overt hypothyroidism. The glands in these patients tend to be a little bit enlarged, so when your TSH is a little bit elevated, your thyroid is going to be a little bit bigger. That's why when we treat people with thyroid cancer, we drive that TSH down, because we think TSH stimulates thyroid cell growth, and if the surgeons remove the thyroid, you don't want any small cells that kind of get going again and cause recurrence of thyroid cancer. So in patients who have thyroid cancer, we give them a little bit more thyroid hormone than they need to keep that TSH a little bit low. Other little pearls that you may want to think about when you're replacing someone with thyroid hormone. I was trained that you always gave someone, when their thyroid came out, about 1.6 mics per kilo. We've actually learned in several studies that the thinner patients, ones with BMIs below 25, in fact need a little higher dose, more like 1.8. Patients that carry a little bit more extra weight, 1.3. Several things can affect the absorption of thyroid hormone, and we'll talk about that in a second. We always tell patients they want to separate their thyroid hormone about 4 hours from any calcium or iron, aluminum hydroxide. You need to think about proton pump inhibitors, which increase gastric pH. Thyroid hormone likes an acidic milieu to be absorbed properly. About 60 to 80% of that is absorbed initially as it moves down the gut. We also would like, in preference, to check the TSH in the morning, because it tends to be a little bit lower in the afternoon. So all these are little angles you may want to think about when you're talking to your patients. But I would say at the end of the day, probably one of the most complicated things in these patients is their compliance. They forget taking medications. So we have to learn how to ask that question. I don't ask them all the time, are you taking your thyroid medicine? They don't want to offend you. I kind of spin it a little bit and say, hey, in the last 30 days, how many of you think you might have missed? And they'll honestly answer that. I may have missed 1 or 2. You don't have to tell them why you asked it, but it helps you interpret the labs when they come back. So lots of things can affect interpretation of thyroid hormone. We're often asked, when is the best time to take the thyroid hormone? And if you look here on slide A, this was sort of a multivariate analysis looking at different times, either taking it with breakfast, or taking it before breakfast, which is on the far left, or taking it at night. The absolute best time to take the thyroid hormone, it would be on the left part of the screen, which is about 60 minutes prior to any food in the morning. There's several things that can affect thyroid hormone absorption, whether it be soy milk, coffee, food. So, you know, I'm very careful in how I explain it to the patient. I'm not saying they can't take it at lunchtime, but if they want the absolute maximum absorption, the best time to take it would be 60 minutes before breakfast. Interfering drugs, we talked about calcium and iron. Other ones to think about when you're rounding on your patients in the hospital. If your patient happens to be on lithium for bipolar disorder, this can cause hypothyroidism as well as hyperthyroidism. I know there's several cardiologists that are here, and amiodarone is also a very big culprit. A 200 milligram tablet of amiodarone has 7 milligrams of iodine. That's 45 times more than the normal daily allowance. So amiodarone has a very high iodine content. If you ever start your patient on amiodarone, you should check TFTs prior. The mechanism of action basically is fairly complicated in this type of setting. However, what you need to remember is that these patients tend to have a little higher free T4 values, a little higher TSH levels. You want to basically treat them if they do become hypothyroid to keep their free T4 sort of in the mid-range of normal. A lot of newer drugs to treat cancers, including tyrosine kinase inhibitors, immune checkpoint inhibitors, these can cause abnormalities in thyroid hormones. A very common consult we get is a patient who comes in with an elevated total T4, a normal TSH. First thing on that patient, are they on an estrogen? Are they on a birth control pill? Because those drugs will cause the total T4 to become elevated. However, the TSH stays normal in those patients. Anti-epileptic drugs are known to cause what we call euthyroid hypothyroxinemia. They tend to cause a lowering of the free T4 with a normal TSH. So if you see that pattern in your patients that are on seizure medicines, that is a very common thing. And heparin can also, through its activity with lipoprotein lipase, cause transient increases in free T4 values. So as we move on to the next case, this is a phone visit of a 50-year-old male. He's been taking Synthroid for the last 10 years for his hypothyroidism. Thyroid levels are always normal, and at his annual visit, he comes in, free T4 is 1.2. His TSH is a little elevated. He says he's not changed his regimen, and in the last 15 years, as I mentioned, he's always been normal. So this is the typical case of a guy that got the reminder call. He remembered he had to go see the doctor, and he thought he'd start taking his thyroid medicines again. He doesn't have a macroadenoma, nothing in the stem to suggest that, although in patients who have abnormal thyroid levels, you should always look at visual fields to make sure they don't have any kind of TSH secreting adenoma. Resistance to thyroid hormones probably at a little higher level in the endocrine world. Those are patients who tend to have elevated free T4s, elevated TSHs, and once you kind of rule out a lot of other things, this is something you may sort of find as the abnormality. I wouldn't expect this guy's TSH to go up from aging. He's 50, that is getting a little old, but we tend to see this more in the 70s and 80s. And nothing here suggested that he had contrast, although contrast can affect thyroid hormones through the high iodine load. Here's another case that was a telehealth visit. This particular lady was 6 months postpartum. Her free T4 is elevated at 3. TSH is of 0.05, which is low. She's lost her weight pretty quickly to her pre-pregnancy weight. However, she's still having some heart racing, a little nervous. You get thyroid levels by the time you see her, she's still elevated with a suppressed TSH. What should you do? The key point on a postpartum patient is to remember that when someone delivers a baby, their thyroid can kind of go crazy. It can become hyperthyroid. It can become hypothyroid. They can get hyper and they can return to normal. They can get hypo, they can return to normal. Or they can go through this triphasic response of hyper down to hypo back to normal over 12 months. So in the postpartum period, we don't really empirically start people on PTU or Methymazole, which are anti-thyroid medications. If she's having heart racing, a beta blocker may be an option. Nothing to send this lady to surgery right away unless you have determined a diagnosis on her of maybe Graves' disease or a toxic goiter. So I would probably put her on a beta blocker and probably follow her up, in a year, maybe a little sooner. The other thing you could probably do would be to get a thyroid scan and an uptake. So maybe 2 answers there, but the scan and the uptake are going to help you because it's 6 months out. If she has Graves' disease, that uptake and scan are going to be high. if she has postpartum thyroid dysfunction, that scan and uptake are going to be low. So that's a very good time to utilize a thyroid scan and an uptake. Nothing in here suggests an ultrasound. And again, the teaching point I'm trying to make is you really need to think through these cases and think about what you really need to order, because you don't want to just see a patient, they have symptoms, and order everything that has anything related to a thyroid, because that's when you sort of get messed up trying to help the patient out. But we do know in pregnancy that the gland increases in size due to the production of T4 and T3. There is a higher daily iodine requirement in these patients. The free T4 tends to come down a little bit, the TBG increases, and when we're interpreting these levels based on the beta HCG from the baby and so forth, the total T4 needs to be adjusted through increased TBG to accept up to about 1.5. Postpartum thyroid disease, again, is an autoimmune disorder. It's a lymphocytic infiltration of the thyroid. The transient hyperthyroidism has low uptake due to the leakage of sort of preformed thyroid hormone. SED rate may be a little bit increased. No pain in the thyroid. The other thing to remember on patients who have thyroiditis is when they're leaking thyroid hormone, that thyroglobulin level tends to be a little bit elevated. We don't order that all the time, but it's always a good board question of, is someone really experiencing thyroiditis, or maybe is the patient exogenously taking extra thyroid hormone to lose weight? Some people do that, and the way to differentiate that would be the blood test of a thyroglobulin level, because someone that's surreptitiously taking thyroid hormone is going to have a low thyroglobulin level. They're not going to have a thyroid gland because it's not going to be enlarged, so that's always a good kind of question that they ask on the board exams or teaching exams. As the patient becomes hypothyroid, obviously the TSH goes a little bit elevated. These patients in the postpartum period, they're all over the board, so you're really trying to help them out. They got a lot of symptoms, they're not feeling well, and reassuring them that this postpartum thyroiditis a lot of times is going to return to normal is very helpful. I'm sort of picking on the female pregnant patients because there's a lot of abnormalities that happen during pregnancy. This is a 28-year-old who had undergone a thyroidectomy before, earlier in her 20s. She had Graves' disease. She comes in, she's been on her thyroid hormone replacement. She had her normal thyroid level when she went to her initial maternal fetal medicine visit, if she was able to get in that quick. She's 6 weeks pregnant and with her first child, and she is taking an over-the-counter prenatal vitamin. Which of the following statements is correct? Again, another important thing to remember in patients who become pregnant is we need to increase their thyroid medication as they advance through pregnancy. The fetal thyroid gland forms around 11 to 12 weeks. So if a patient shows up to an endocrinologist or to your office at 15, 16 weeks and their TSH is 20, 25, you're not really doing them justice. So I always tell my patients who are thinking about pregnancy in their childbearing years, who are already on thyroid medicine, to definitely let us know if they get pregnant, because you want to increase by 30%. Basically, that's telling them to take an extra pill 2 days a week. So if they're on 700, 30% of 700's 210, 210 spaced out over the weeks, an extra pill 2 days a week. During each trimester, though, you have to check their thyroid levels. The other one, if you remember these type K questions from med school or PA school or nursing school, if one's right, three's right. So 3 is right. You should have the thyrotropin receptor antibodies checked. And very important to let the GYN know that, or the obstetrician, because these values can pass through the placenta at delivery, can lead to neonatal thyrotoxicosis. Always important to let the GYN, OB/GYN doctors know. Iodine is something that needs to be present in the prenatal vitamin. Up to about 250 micrograms would be good, because women who have thyroid disease waste iodine during pregnancy, so you got to supplement that. Waiting at 12 weeks is a little bit too long. There was an old New England Journal article back in the early 90s that talked about people who had hypothyroidism early on might have had lower IQs. And that's been refuted over the years, but at the end of the day, check these people early, get them on thyroid medication, make sure they're taking their prenatal vitamin, again, separating it properly. Here's another patient that's a very common thing we see. A Hashimoto's patient, female, sends a portal message. These portal messages they'll wear you out. She wants to discuss some thyroid hormone levels from her OB. She's 14 months postpartum. She's breastfeeding. She's not on any medication. She's gotten her weight back down. Baby's 1, so she's starting to go to these little book club meetings, getting out of the house a little bit. And at her book club meeting that's still masked, she was telling her friends that she's got some dry skin. Her nails are dry. Her hair's coming out like crazy. Pregnancy, we do see hair coming out. You check her thyroid levels and her free T4 is elevated, 3.1. TSH is normal. And she doesn't have any kind of signs of thyroid eye disease and her gland's normal. What would you do? So right here, if you look at this, she's got a normal TSH. She's got a high free T4. She's really past the time of the postpartum thyroid dysfunction. She's about 14 weeks. Her TSH is normal. I don't think you need to put her on anti-thyroid medications. I don't think this would be a little odd for somebody to have pituitary resistance to thyroid hormone. Nothing here talks about needing to do an ultrasound. Again, don't just order one because you got some abnormal thyroid levels. I don't think you need to see if she has Graves' disease. I mean, that's not going to be helpful. A very common disorder we see now is biotin use. So this lady probably, somebody told her at the book club that you ought to take some biotin. You can't take biotin and check thyroid levels. Biotin will affect the assay of the blood work. So anybody who is taking biotin needs to hold their thyroid medicine for at least 48 hours. We live in Alabama. I tell them a week, and hopefully they'll do it for 48 hours. So make sure anybody taking supplements is avoiding biotin. It doesn't mean they can't ever take it again. They just have to avoid it for at least 48 hours. This is just sort of a table from a real interesting article in the New England Journal. If y'all are interested in pulling articles on thyroid dysfunction by Birch in 2019, really a nice just discussion of all types of drugs that may affect thyroid hormone, where they affect it. Yes, ma'am.
I would just add to that a lot of these women's one a day, like, you know, it's easy when the patient says they're taking hair, nail, and skin vitamins, but now a lot of these like women one a day and all of these kind of like wellness and actually just regular multivitamins have increased their biotin content. So a patient will deny taking that, but then I say, oh, you take the multivitamins, ask them the name, Google it, and there's like, 3,000 micrograms or 300. So
yeah,
I usually will tell them not to take any supplements or anything for the 2 to 3 days.
Dr. Towns is exactly correct. I mean, some people think that it's 3,000 or 5,000 milligram biotin tablets. Studies have shown even 10 milligrams of biotin will affect the thyroid level. So again, we got to drill them out on what medicines they're taking and avoid them. Thanks for sort of bringing that point up as well. This again is sort of an anatomical site of just where some of these drugs kind of act. I'm going to show you the sort of pictures of the assays. This is again a summary of some of the drugs and their effects on thyroid hormone. You see biotin there causes high free T4 levels. It can also cause low TSH levels. There's 2 types of assays if you're interested. There's a competitive assay as well as a sandwich assay. The sandwich assay tends to cause the TSH values to be a little bit low. The competitive tends to cause that free T4 levels to be a little bit high. So again, I don't think we necessarily need to know all the details, exactly of how this works, but biotin has really led to some improper treatment of patients over the years. People trying to treat them for hyperthyroidism, people trying to maybe even take their thyroid gland out. So thinking about biotin, as Janelle mentioned, looking at other types of supplements that patients may take. In the world that we've been experiencing with COVID, you know, thyroid has also reared its head in this problem. 38-year-old female who has had some neck discomfort that developed about 2 weeks ago. She states that prior to her neck pain, she had developed COVID-19 and had minimal symptoms, and she properly quarantined. When you do see her, she has a boggy thyroid, slightly enlarged and a little on the tender side. You cannot examine it very well because it's painful. She's not had any type of weight loss. She's not had any hyperdefecation, but she has experienced a heart racing. She has thyroid levels showing a free T4 that is elevated at 3.62. Her TSH is completely suppressed at less than 0.01. Which of the following conditions is most likely? Hyperfunctioning nodule, hemorrhagic thyroid cyst. That's a potential, but if you look back at the stem, talking a little bit about coronavirus and so forth, subacute thyroiditis is a condition that can occur after any virus, even the virus that we've been dealing with over the last year to two. Graves' disease and Hashimoto's are probably a little bit less common. So thinking about subacute thyroiditis, because it's of viral origin, I think when you see patients, or if you're an ear, nose, and throat doctor, or you get a patient from an ear, nose, and throat doctor, they tend to pick these people up a lot. They have a tender thyroid gland. They have referred pain to their ear, always a good question to ask your patients. A lot of times by the time they make their way to an endocrinologist or even to a primary care doctor, they may have already started to go through the process, and you may see them a little bit late. So I always kind of ask, within the last 6 weeks or so, do you recall having a virus? And if they say yes, it's kind of helpful in making this diagnosis. The course is self-limited. It consists of a hyperthyroid phase lasting up to about 3 months. It's followed by a mild hypothyroid phase that can go another couple months, and then usually they return to normal. Any of these thyroiditis patients, you can't leave them alone. You need to keep an eye on them, and at some point down the line, follow a free T4 and a TSH, because in theory, they could become hypothyroid. Again, these patients have been seen commonly in the hospital during the pandemic. 5 to 20% of these patients develop permanent hypothyroidism. Treatment of choice is steroids, beta blockers, and nonsteroidals. We don't want to give the anti-thyroid medicine, and to be complete, you know, these anti-thyroid medications have sort of changed a little bit in the last decade. We used to use PTU and methimazole. Now, with the black box warnings of PTU, its effect on liver, we tend to just use methimazole unless it's the first trimester of pregnancy where we would use PTU. I do tell and document every one of my patients who is going to go on methimazole the rare side effects of methimazole, which are agranulocytosis, a lowering of the white blood count, or hepatitis. And these can be idiosyncratic. So it's not like if they've been on methimazole for a week, they're good to go. They can have it at any time. And that's the reason we don't leave people on anti-thyroid medication sort of lifelong. If you can't normalize their thyroid on methimazole 12 or 18 months, I tend to try to withdraw them to see if they normalize. If they don't, then I think more along the lines of definitive treatment with radioactive iodine or surgery. The other common side effects with anti-thyroid medications are pruritus or rash, itching, those type things also may compromise patients from using these drugs. I don't know if everybody on video understands what the MISS line, that's a local UAB number where we assist providers in the state and the surrounding states to, or actually across the country, to field consults as needed. And you are contacted by the MISS line to assist in the management of a 72-year-old that recently started immune checkpoint inhibitor therapy, ipilimumab and nivolumab for malignancy, and she's developed abnormal thyroid levels. Her free T4 is elevated and her TSH is suppressed. She's lost a few pounds. She's had some fatigue and heart racing. And the question here is, what would you do for this patient in addition to starting them on a beta blocker? I mean, we're pretty sure that these drugs, these immune checkpoint inhibitors, can cause thyroid dysfunction. They do cause a thyroiditis. The key point here is that you continue, or usually we're not the ones continuing, it's the oncologist. We wouldn't stop this medication. This is a very common thing that we see, hypophysitis, we see thyroiditis in these patients. Again, anti-thyroid medications and CBCs are not really what they need. What you need to remember in these patients is you want to start them on a beta blocker, but you quickly want to start them on thyroid hormone replacement, because these drugs that are used for cancer treatment cause a destructive thyroiditis, and it tends to happen pretty quickly. They are in the hyperthyroid phase. They tend to show a low free T4 and a low TSH. So the TSH tends to lag a little bit behind the free T4. So you don't want to just wait for that TSH to become elevated before you start the patient on thyroid hormone. Once you see the free T4 low, you need to go ahead and cover them with thyroid hormone replacement. A very common treatment, as you see here, 44% of the United States patients a couple years ago were on this therapy. Autoimmune side effects are very common, not only hypothyroidism. I saw one from one of the GYN oncs the other day. Fatigue, lethargy. They did a random cortisol. It was 0.4, which is low. We did a cortisol stimulation test where we checked the baseline cortisol. We give them the cortisol. We check the cortisol level at 30 minutes and at 60 minutes. Basically, any cortisol above the number 18 suggests an adequate reserve. This patient went from 0.4 to 2 to 2, so she was buying Cortef to get her on. She developed secondary adrenal insufficiency. We can also see florid type 1 diabetes also develop in these patients. These drugs work by leveraging the immune system to fight cancer cells, and in the process of that cause destructive cell-mediated thyroid gland inflammation, predominantly affecting CD4 and CD8 cells. The one good thing about this is that when you do see this response, they tend to do very well from their cancer perspective. It's been shown in studies the patients that do develop dysfunction or inflammation, autoimmune in nature, tend to do better on the other side. So it's reasonable to check some thyroid stimulating immunoglobulins if it doesn't return, but a lot of times you're going to end up seeing these adverse effects and this sort of return. So initially they developed thyroiditis at around 2 to 3 weeks. They get the hyperthyroid phase about 4 to 6 weeks, and then very quickly they get hypothyroidism, and hopefully they're sort of treated here. And you can see that here on the slide with these curves. This is the TSH on the y-axis here in the blue line, again very, very low, and as it's starting to come up, the total T4, which is in the red line, on this axis, you see coming down very low. So you really want to get them started very early on thyroid hormone replacement and follow their TFTs. So treating the hyperthyroid piece of this would be a sort of reassurance, getting them on beta blockers, checking these TFTs every 3 weeks. As I mentioned, the TSH lags. It's a destructive process, 50 to 90% permanent. Some of these patients may have some gut abnormalities, so the absorption may be a little difficult. There's other ways to treat that with other types of thyroid hormone. There also could be some, you got to keep in your back of your mind other potential causes of a low TSH, whether they're on dopamine agonists in the unit. Steroids can cause a slight suppression of the TSH, but again, no need for steroids and no need to stop the immunotherapy. The other thing, as we sort of start to wrap things up, I'm frequently asked about combination therapy with T4 and T3. Usually in those patients, I send them over to Dr. Towns, but no. T4 and T3 tends to sometimes be used by alternative doctors. most of the T3 that is in the body is sort of converted from T4. So you probably, maybe there's about 5 micrograms of T3 out there that could be needed for the patient. But what we usually see is that these patients have normal TSH values, they have normal free T3 and normal free T4. The problem we get into a lot of times is if they go see an alternative doctor and they're placed on Armour Thyroid, T4, T3 combination products, they get several grains of this thyroid hormone and they drive that TSH down. So they are effectively becoming iatrogenically hyperthyroid. They feel a little bit better. We could put 100 people on T4 and T3. The problem, though, is that we are placing those patients at a high risk for atrial fibrillation as well as osteopenia. So I tend to avoid those. You know, I think it's not that we're doubting their symptoms, but again, remember what we said, when the TSH is normal, we feel pretty comfortable that their symptom complex is not thyroid related. But there are Facebook pages, there are group sessions that talk about your thyroid doctor doesn't know what he's talking about, you need to get on T3. I just would be very careful if you go that route in treating your patients. So what have I learned from thyroid and telehealth? I always ask my patients if they have a primary care doctor. I mean, we're here to help them. We want to be empathetic in their care. We don't want them to feel bad, but I feel it's our job to say, is this related to the thyroid? And if I can rule it out and feel comfortable it's not related to their thyroid, I want to get them back to their primary care doctor, make sure they understand that they've had a consultation and the specialist doesn't feel that it's sort of indicated. Ones that have seen an endocrinologist in the past, I always like to ask them why they're seeing me. Because at least in our community, we have excellent endocrinologists. Most of the time, there's a lot of doctor shopping going on. They'll see 5 or 6 of them. They didn't like their staff. They didn't like the doctor. Usually those patients tend to be a little bit of a problem in trying to get you to get them T3 or this or that. I think another important thing is to find out when you started on the thyroid medication, why did you start on it? It's sort of a question that I sometimes forget to ask them, but if they walk in and they're on 75 of Synthroid, I want to try to ask them, do you recall why you started on it? Sometimes they're going to say, you know, my numbers were fine. He just thought that it would make me feel better. Well, those patients may not need to be on thyroid hormone and you could be hurting them. So asking why they started it to me is something that I've spent a lot of time trying to do it. How do you take it? Are you taking it with soy milk and coffee right when you wake up in the morning? You're not going to be absorbing it correctly. Are they taking it at night? Are they not taking it? Brand name versus generic. Again, insurance companies dictate that. If they take name brand, they tend to do a little bit better because the pill is equal dose to dose to dose. Generics have a wider standard deviation, about 10 or 20% on each side. I'm not saying I put everyone on name brand because you can't fill out PAs to get these approved. However, cash price sometimes about the same. So sometimes tell them to check and see if they can afford it, and if they can do name brand, do it. There's gel cap forms, a new delivery system. Tirosint is a drug that is a little bit more pure. There's no fillers. I have seen people who are on Synthroid or on a different dose of Synthroid that develop hives and rash. The dye in the products sometimes can affect them. If you're interested, the dye-free pill is the 50. So I have one lady who could not take 150, but she can take 350s because it's dye-free and she tolerates it. I mentioned to you about the thyroid pills. How many of you missed? Asking about the interfering drugs. How often do you fill it? Hoarseness and swallowing is a great question. Compressive symptoms. Saw a lady last week. She was in her upper 80s. She was in with her son, and she really wasn't talking that great. A little bit of stridor, and I'm not an expert on determining stridor, but she had some stridor. You could hear it across the room. Brand new patient, got her to the ENT same day. So talking about hoarseness, stridor, swallowing. Thyroid imaging, we don't want to repeat these all the time. I mean, there are some facilities that are just doing quick thyroid ultrasounds and really not doing a great job on them. I think most endocrine people have gone through thyroid ultrasound training courses. So making sure that the imaging is done correctly, not just sort of taken for granted that they had an ultrasound. We tend to repeat it a lot. Previous history of radioactive iodine therapy. Again, you got to drill down. Have you received radioactive iodine before? It can help you in your interpretation. Sometimes they come in, someone wanted it out, they didn't want it out, over-the-counter supplements. We've talked about sort of all these things. If they have this shirt on, you're probably in for a long clinic visit. I would say that. And if they have a thyroid book, you're probably in for a longer one. So with that, we'll end it. I'm happy to take any questions. This is a little good luck thing my daughter told me to when I went over the presentation with her and told her what I was talking about, to make sure that we always get those book club minutes and make sure that the prenatal vitamins do have iodine in it. So thank you for your time, and I'd be happy to take any questions for the local people. I guess the only other thing I would just sort of close, because I didn't really have any slides, is thyroid cancer is very common. We see it. Most patients do very well. Different types of thyroid cancer are the papillary and the follicular, which make up about 90% of it. These patients tend to receive radioactive